now hand over to Emma. So Dr. Emma Sandford.
Thank you. Hi all. Is that close enough? You can hear me okay? All right. Thanks very much for coming of an evening, a Wednesday evening. I have given talks similar to this a number of times because it's something that really is very close to my heart, and it was the beginning of my journey. Diabetes is regarded as a global epidemic. In 2021, approximately 500 million adults were living with diabetes, and that's expected to increase by 2045. 30% of those are estimated to have diabetic retinopathy, and 10% have sight-threatening diabetic retinopathy. And this is interesting because it often happens in working-age people, so a lot of eye diseases that we are commonly aware of, like glaucoma and cataract, occur in the older population, often the retired population. In high-income countries, retinopathy is now the fourth common cause of moderate to severe visual impairment. So it's becoming, there's an economic imperative, if nothing else. In New Zealand, it is also increasing in frequency and in younger and younger people. And again, that's going to be on the increase, just as our obesity rates, etc., are as well. The risk factors for getting complications in diabetes are your high blood sugars, high blood pressure, cholesterol or lipids that are dysregulated, so abnormal lipid profile, and also your duration of diabetes. And controlling these will definitely reduce your risk of complications. And controlling these can reduce your risk of complications that are sight-threatening by 50%. So instead of just rocking up to your ophthalmologist and having more and more laser or injections or whatever, there are things that you can do about it. And the other thing to recall is that diabetic complications across the whole body are a reflection of what's going on in the body, which is not only dysregulation of sugar and lipids, but inflammation. Complications otherwise are that you get kidney disease, nerve damage, foot ulcers, atheroma, heart attacks and stroke, male and female sexual dysfunction, thyroid disease, tooth decay, gum disease, depression, dementia and cognitive impairment. So these are perhaps regarded as comorbidities. They happen in the same body for the same reasons. Complications in the eye are diabetic maculopathy, which has a number of different sorts, ischemic maculopathy, diabetic background retinopathy, proliferative diabetic retinopathy, proliferative vitreoretinopathy, and then you also get early onset and rapidly developing cataracts and an increased risk of glaucoma. So, when you're going to see your eye specialist, they will be checking you for all of those other things because you have an increased risk of them. They are related diseases. People with diabetes are more likely to need other eye surgeries as well, including epiretinal membrane, which is most definitely driven by inflammation. We undertake screening in this country, and people who have been diagnosed with diabetes are invited into the retinopathy screening program. The difficulty is that often people will present and they have had diabetes for quite some time before they're actually diagnosed. So sometimes they have retinopathy as you sit in front of them, and that's one of the things that they'll go through for an examination, and they might be immediately into treatment. So screening is important because you may not notice a visual impairment. You may not notice that you've got problems because if it's not interrupting your central vision, you're unlikely to see it. It happens in little isolated blobs. Unless it's connected into one big blob, at your macula, hence the maculopathy, the most sensitive part of the eye, then it often goes unnoticed. So this is the part where if you just cast your mind out to what you've already been told about your retinopathy and your diabetes most particularly, and I just want to point out that this is happening all over your body and in every blood vessel of your body. So in the retina, cells that line the blood vessels and support the lining cells and support the blood vessel cells start to die off. And these cells are really, really important because they're kind of like the gatekeepers and the caretakers. The membranes on which all of these lovely cells sit become very thickened, which means that the passage of the good stuff from the blood into the tissue becomes more difficult. And passing the bad stuff back from the tissues into blood vessels also becomes more difficult. Capillaries start to suffer, they just can't cope anymore, and they just close and die. And this just increases inflammation, it decreases blood supply to the back of the eye, and that's when the retina starts sending out signals of, I am really unhappy now. And it starts sending signals of a particular hormone, VEGF, and it's a signal to make new blood vessels. It's also a signal that make existing blood vessels leak, including leaking blood, so in other words they bleed. Now this VEGF is great when you're in utero and you're forming your limb buds and growing new blood vessels to grow into those lovely limb buds. But from about 6 months of age, that becomes a problem in that the body loses that capacity. And when those signals, that VEGF signal starts, you are only able to just about to squeeze out a few abnormal blood vessels. And they do not supply more blood, they do not supply more nutrient, they leak, they bleed, and they are extremely active in scar tissue, which is where a lot of the other explanations and factors and features of retinopathy come from. Nerves and their specialist support cells are also affected by this scenario. So there are lots of different sorts of diabetic retinopathy, and I'm just going to run through them one by one. Diabetic maculopathy, this is pretty common, and it's a late complication and often happens when you've had diabetes for 20 years, particularly if you've not looked after your blood sugars, lipids, blood pressure, etc. People will suffer from a decrease in vision, loss of contrast sensitivity and colour vision, and when the retina becomes really swollen, the mechanics of how the brain interprets that becomes different. So it gives you a depth perception, which means that your brain goes, oh, well, instead of the doorway being straight, it's got a wiggle in it. And that is what is showing you how big that area of swelling is. Sometimes it just looks like a black or grey smudge in the centre of your vision. We will see swelling, we will see little bits of fat and protein that's leaked out of blood vessels. We may even see that some blood vessels are starting to get blocked off. You might have little aneurysms poking out. And that's what it looks like. So on the one side we have one form of maculopathy where you can see that the details of the blood vessels on the left-hand panel are less obvious because they're actually out of focus with the camera, because they're sitting forward because of this swelling. And around that is the lipid and protein that's leaked out of the blood vessels, as it should, because that's how your cells get hold of it, but it's not drained away again. And the plasma hasn't drained away again, the fluid, because both the arterial side and the vein side of your circulation are sick. And in the middle there, you've got a couple of little red spots, so they're hemorrhages, little bits of blood that's also leaked out. This is another example. They all look different, everybody's different, but they'll follow these sort of patterns. On the right-hand panel, you've got an area of swelling, and you've just got little spots of exudate.
Emma, can I
can I just slow you down a little bit?
Yeah.
So what are you doing here? So you're looking through the pupil into the back of the eye?
Yes, yeah.
And what's that that moon there?
Okay, thank you.
And what's that bit there?
Absolutely, thank you, Glenn. So the moon, as Glenn described, is the optic nerve head. So your retina is a really cool piece of equipment. It is almost wraparound. It almost comes right to the front of your eye. So where you see the coloured bit, your iris, and then the black spot in the middle, which is your pupil, is actually a hole. It's a little black hole that the light disappears into and lands on that retina. And your retina wraps all the way around, almost to the front, which is why I can still see my hand moving out here and I can just about see my feet. And all of those nerves scoot round to the optic nerve head, where they take a 90-degree turn and dive off to the brain to tell your brain what's going on as far as what they've seen today, what they've seen this second. The blood vessels are going in and out, so the finer, thinner blood vessels that are more sort of salmony orange, they're the arteries, so they're coming from the heart to supply the retina, giving off to little capillaries, feed the cells, and they go, oh yeah, I'll take what I want, give away what I don't want. And then the little veins come in and get bigger and bigger like tributaries of a river, get to the really fat red vessels and dive back down again and go back to the heart and the lungs. So that's the conduit. That's the conduit for the nerves and the blood vessels. And then the area of where you've got the leak over there and you've got these little spots over there, that's the macula. That's the most sensitive part of the retina as far as facial recognition, your colour vision, your reading, so all of your stitching and knitting, all of your fine work. The outside of the retina is more for dark and less detail movement, for, you know, saber-toothed tigers dropping down and snakes on the floor, that kind of thing. So that's your peripheral field. Very, very important for driving, so that you're spatially aware. But as far as the fine stuff is concerned, that's the part of your eye you're using. So diabetic maculopathy is, you know, fairly significant for somebody who's got that amount of swelling. The cells are just not functioning. They're just not able to speak to the brain anymore. They're sick. And the next form of diabetic maculopathy is ischemic. So the left-hand panel, you can see that's, instead of beautiful and salmony, it's got lots of white smudges and red smudges. So you've got lots of blot hemorrhages and you've got lots of exudate. So that's a pretty sick retina. And it's all over. And the right-hand panel for you is a fluorescein angiogram where we put dye into the blood vessels and see where it goes. So it will obviously come through the arteries first, it will go into the tissues, and if you've got leak, it will show you the leak, and then up back it comes. And you can see the black patches of that moth-eaten appearance. Instead of being this lovely grey colour where you've got a general filling with the fluorescein, you've got these black areas that have no circulation whatever. That's a really, really sick eye. And remember, this is going on in your whole body. This is not good. This is really not good. Your beautiful brain, your heart, your liver, your kidneys, everywhere. So this is quite serious, and this is tremendously difficult to treat because we can't grow people new blood vessels. So what we aim to do is avoid going there in the first place, which is actually where you come in. Yep, so I've just been through that. And the remaining blood vessels that are passing through this area with no capillaries, they get even more distressed. So they start to leak, and it just sort of compounds. It gets uglier and uglier unless you stop what you're doing and have a think. So treatment options, this is mostly for the leaky type, the normal maculopathy. So what we're doing is inducing a very tiny thermal burn at the back of the eye. So we dilate your pupil mostly, put you on a machine, and use the laser to make these tiny little bits of trauma. And that trauma is a signal for the body to get to work and do some housekeeping and suck all that fluid out and get its house in order and see if we can get that to, get back to where it needs to be. Sometimes you'll see little aneurysms, and you can seal those off with those burns, which will certainly help the leaking scenario. This situation does come and go, so you can watch people, but there'll be a certain point where we say, oh look, this is definitely going downhill or really severe. We know that people get better quicker if we give them laser. So that's what we'll do, and sometimes we will add in an injection to inhibit the VEGF signal. So it blocks that hormone from sitting on the blood vessel, say, hey, come on guys, grow some more blood vessels. No, don't take that. And that stops it in its tracks. They usually last a month, so they would be a repeated procedure, or something that we just use to hold you while the laser takes effect and everything starts to calm down. So usually within 4 months we'll see what the effect has been. Other laser options exist. There are more and more clever machines, but basically we are trying to stress the sublayer to get things moving again. It's a little bit like acupuncture. We're creating a tiny stimulus to create a bigger response. We could also decide to give you steroid injections. We've got depot injections now, so we don't have to give those quite so often. And there are lots of medicines that will block the VEGF signals. The non-proliferative diabetic retinopathy, this is often what we see through screening, and hopefully that's where you stay. As you can see, there are no new blood vessels, but we do need to closely monitor, because these are the sort of people that can tip into proliferative. So all the vessels are sick and not particularly happy. On the left-hand panel, I don't know, probably an educated eye could see that the veins are quite dilated. They're a little bit beady. They're not smooth and gorgeous. Lots too much going on. And in the right-hand panel, you can see there's an ERMA. So there's an anastomosis between the vein and the artery. It's just really trying hard to open up. It's kind of like your detour. So instead of just going on your state highway, they open up a detour, and maybe they'll mow the lawns and mow the verges to make it easier for you to pass. This is kind of what the body does. So in proliferative diabetic retinopathy, this is where it's starting to get a bit more serious. Although it's all serious because of impact on vision. The blood vessels are sick, they close up and they die, and this is where you get these areas of retina that are just not supplied. The VEGF starts to be released, and you get these new blood vessels forming. They leak, they bleed, and they create scar tissue. And the scar tissue can run amok just on its own because it's very, very active. It's progressive without intervention of some sort or another. So we do tend to intervene with this fairly PDQ to prevent the bleeding and prevent the scar tissue forming. Left untreated, it will generally lead to tears. So this is a couple of pictures. Anybody can see that there are some very strange things going on. At the disc there on the left-hand panel, there is a great big frond, several great big fronds of abnormal blood vessels. And then if you go up a little bit, there's another great big one that's flat onto the retina. And the right-hand panel, well, there's a lovely flower of them right in the middle. And this is what your fluorescein angiogram might look like by this stage. So you can see there's an enormous percentage of the retina that's got no blood supply. So no wonder it's sending out these messages.
Could you explain what the fluorescein retinopathy?
A fluorescein angiogram, yeah, sure. It's a special camera with filters, and you give somebody, you put a cannula in, you inject the dye, it's basically a dye, and it's a dye that gets excited by a certain wavelength of light, and then the atoms give off a different wavelength of light and that's what the camera captures. And that means that you can, because it's supposed to stay in healthy blood vessels, it will stain abnormal blood vessels and it will leak from sick blood vessels or new vessels, because these new vessels are rubbish, right? They just leak. So we can find out, if we can't see everything, and we can get a picture of how bad your retinal circulation is. So I would use this information to know exactly where to put my treatment. So instead of blasting the whole retina, I would probably just blast the black bits. So I'm going to kill everything, just absolutely, it's sick, it's got no circulation, it's not growing on back. It's like amputating a gangrenous leg. Everybody feels better. Instead of, just willy-nilly. So it can be very, very useful for directing treatment. Again, you can give these injections, and that's really useful because it kind of settles things down before going in like a cowboy and blasting everything. Because if you shrink these abnormal blood vessels too quickly, then they can get caught up by their own scar tissue and pull away and bleed. So sometimes what we do is give somebody an injection, and then in a couple of weeks, when things are a lot less angry and swollen, then we'll go in and do that. So argon laser is your most common. So this is something that I was doing at the eye clinic. And you're basically selectively destroying, which is a bit of a interesting thing to know that you're doing to somebody. And you selectively destroy the outside. Remember when we talked about the macula being your central, your facial recognition, color, TV, and reading? That's what we're trying to protect from everything else that's going on in the retina, and say, look, they can do without some of their peripheral vision. We're not got saber-toothed tigers, we haven't got snakes, we're probably going to be all right by compromising their peripheral vision. And we leave you with gaps. So most people are unaware that they've lost that. But when we have to go back a second or third time, then we have to fill in those gaps. And then you are aware, and you end up with a tunnel type vision, because we've sacrificed your peripheral retina to stop the mischief, so that we protect your central retina and therefore your macula and therefore your vision. The vision that you use and value more greatly than your peripheral vision. The abnormal vessels usually behave themselves and they shrink and disappear. Any hemorrhage in the jelly of the eye resolves over several months, and you reduce the sort of activity of that scar tissue. Instead of being rabid and rampant and pulling off the retina for you, it will just start to settle down because you've taken away the signals. Yeah.
At which stage of this would you lose your driver's license?
That depends on your vision, your binocular vision. You should be able to get about 2/3 of the way down the chart to 612. We also test the number of degrees of arc that you can see in the periphery. If I look at this lady with a lovely purpley black top, then I can still see my fingers up here and down here. So that's my peripheral. So there's a certain degrees of arc that are required in each direction for each eye, and then binocularly, actually we test you both eyes open, because nobody's going to go around, oh, can't see that child running across the street in front of me. You use both. So that's how we test you. But mostly for diabetic retinopathy, because of where it affects, we're mostly interested in your reading your Snellen chart vision, and 612 is your legal limit. Anything less than that, and you're going to be asked to hang up your keys, even if it's temporary. So, yeah, I think we've talked about this really. It just switches off the signals and switches off a lot of the inflammation. because we need to protect that central vision. If there is a hemorrhage in the jelly, so one of these blood vessels is torn and bled into the jelly of the eye, which occupies that middle segment. So at the front, you've got the cornea. I'll choose black, actually. So at the front of the eye, you've got the cornea. This is not to scale. And then you've got this great big, this is the white of the eye. And this is the window of the eye. You've got the iris and the pupil in the middle, little black hole. So that passes through, and all of this is jelly, and this is your retina and your optic nerve. So all of this is jelly. So you can imagine these blood vessels leaking and bleeding. That's where it's going to end up, as well as on the surface of the retina. So when you've got one of those on board, it makes your life difficult and ours, because we can't see the back.
If you reversed your diabetic, changed your diet and did all that, none of this would reverse, would it? Because this is permanent.
Actually, it would. Because if you stop knocking your head against a wall, your head stops hurting. You're taking out the drivers. Now, I wouldn't say that all of it will reverse, but you can get rid of new blood vessels, you can get rid of leakage. I've done it with patients. So it is, this is why at the beginning I was talking about, if you reduce the complication risk factors, you reduce the impact, you reduce the consequences. Absolutely. This is all in your hands. And I know this is all doom and gloom and, oh, God, blimey, thanks very much, I feel terrible. But, towards the end, it's, and what are you going to do about it? So you're absolutely right. It's eminently moderatable, mediatable. So we might also add injections if a jelly hemorrhage is persistent. I can't see in to do the laser, so we just need to get rid of them until I can see to do the laser, because you've got all that blood in the jelly. Sometimes new vessels will fail to disappear even with panretinal photocoagulation. We can go back and do another heavier session, but there are people who have just damaged their blood vessels so severely that there's not a lot left. Okay. Now, some people are so severely ischemic, in other words, lack of blood vessels, therefore lack of oxygen, that even new blood vessels start forming elsewhere in the eye, including right at the front. So we talked about, just briefly, the anatomy of the eye here. So the cornea has a certain thickness, and here's the iris, but in here is a very, very special area. Then you've got the lens. Sorry, I forgot to draw the look because it seemed irrelevant, but there you go. That's the sort of what focuses this light coming from here and further in, and it lands on the retina. Sorry, not to scale terribly. So your fluid that bathes the front part of your eye is formed in this ciliary body area. It comes through the pupil, distributing all around, and then drains into the trabecular meshwork. And this is where abnormal blood vessels can form as well. So this is the sort of thing that happens in an eye that's had a central retinal vein occlusion, for instance, where yet again it's some reason that the eye has lost its blood supply and it's got these signals, and it will grow new vessels everywhere. It's got no blueprint or instructions, so it just does what it knows, and you'll end up with glaucoma. So this is what I'm talking about here with neovascular glaucoma. So this is yet another consequence of what's going on in the eye, and for the person for the diabetes.
Emma, could you do the very beginner's explanation of what glaucoma is?
Yes, thank you. It is crudely a mismatch between water from the water producing area, aqueous as we call it, it's basically a flash name for water. You're producing more than you can get rid of. So it's like having hair in your plug hole, but you've got the tap full on. But you've got a closed system, so the pressure goes up. And that's what glaucoma is on a very basic level. You know, glaucoma in this situation where you've got blood vessels blocking the exit is like, you know, fluff in your pipes. But for other sorts of glaucoma, you know, there's blood supply, etc., as per the previous talk. Okay, so this is where you've got more going on than surgery and injections can handle. And you are going to need to see a man with a knife because he's going to need to clean it out for you. So it's like cleaning your drains because, you know, the nice approach won't help. And sometimes these blood vessels just keep on bleeding and the jelly hemorrhage won't disappear. And we're worried because we can't see what's going on that actually scarring's going on. So that's what he or she will do. Proliferative vitreoretinopathy, this is where the blood vessels actually grow into the jelly of the eye. So instead of staying flat on the retina like you saw in all those other photos, it starts to protrude right into the jelly. And as you can imagine, whenever your eye moves, that jelly moves, rip, and it's very easy to have a vitreous hemorrhage in that situation. And they can become very active in the scar tissue. So this is a picture on the left. Somebody has developed a great big swathe of abnormal blood vessels, new blood vessels, and you can see the scar tissue associated with it, the white. And in the right-hand panel, this person has basically got a retinal detachment because it's just whipped it off like a fisherman bringing in a net. Just hang on a second. Ooh, I pressed the wrong button. Okay. As time goes on with poorly managed diabetes, your chances of running this gauntlet of progression gets more and more probable. And again, that's where you come in as far as controlling these risk factors, particularly your blood sugars, your blood pressure, your cholesterols, and your inflammation, which is something that we don't talk enough about, in my opinion. So, the natural ophthalmology solutions. You know, I was getting to the point where it was really difficult to keep my mouth shut with what I knew because of my naturopathy degree. I knew we could do so much better. I knew we could do so much more. I knew people with diabetes, you guys, could be educated and invited. And if you don't want to, that's absolutely fine. But if you don't know, you can't make an informed decision. So that's when I decided to do my naturopathy degree. So it was diabetes that got me into the whole rest of my journey over the next 10 years. And it's remarkably straightforward, but changing habits of a lifetime isn't. And that's why we all need help, education, support. But basically, eat right, move right, take control, enjoy life, and consider herbs and supplements as needed. Control diabetes in all aspects, your blood sugars, your inflammation, your blood pressure, and your lipids. And you know what? If you attack one, you'll probably approach them all because they're all related. You remember that list of diseases or problems that diabetics get? They're a suite. They're brothers and sisters. So if you control your diabetes, you reduce your blood pressure. Great, awesome. You're going to reduce your risk of heart attack and stroke. Well, that sounds really good. You're going to reduce your peripheral neuropathy. You're going to reduce the rot on your kidneys, because by the time we're seeing those new blood vessels at the back of the eye, you've got the same thing going on your kidneys. We know that we are instantly going to be looking for beginnings of renal failure. And that's, you know, I think people stay fairly settled with, oh yeah, I've just got some more blood vessels. Okay, treat them. And it's over and done with, and off they trot, and they go and have a McDonald's on the way home or whatever. I know I'm being facetious. But when you let them know that this is going on in their kidneys, then it takes on a whole new level of, oh. And that's why I became so passionate about education and informed choice, and helping people understand their disease process and what they can do about it, because there's plenty, which is what Glenn knows all about and does with aplomb. So I think you might have heard this song before. Low carbohydrate, high good fat diet. And it's funny because when I was at university learning about physiology and pathophysiology, so diabetes is an inability to shuttle sugar from the blood into the cells because they lack insulin that is that shuttle. Okay, so why is it that we're recommending people have complex carbohydrates? Because they still digest to sugar. A bit more slowly, yeah, great, but it's still going to turn to sugar. So what about, fat? Oh no, we can't give them fat because of heart disease. So this is, the lipid hypothesis and Ansel Keys and all of that incredibly flawed research that has been turned over, 50 years ago? And we're still in the mainstream harping on about that as our gospel pathology truth. And it's just not true. So the low carbohydrate, high good fat diet has been proven. I've got 100 more references than that. You can go and PubMed it yourself. Go on to PubMed and put in your terms of low carbohydrate diet for polycystic ovary or autism or epilepsy or any number of these diseases, which are all cousins. So we've got the brothers and sisters within a diabetic patient, but now we've seen the cousins. So that's why diabetics suffer from more Alzheimer's, Parkinson's, polycystic ovary, etc. So a good diet, by all accounts, referenced highly, as well as my own experience and opinion, is a traditional diet. Doesn't matter what traditional, whatever your genealogy tells you. If you're Caucasian, then probably something Northern European. If you are Indian Caucasian, then it's probably a traditional Indian diet. If it's Māori, then it's going to be a traditional Māori diet. And they have some extremely interesting commonalities. So Weston A. Price travelled the world in the 1920s and 30s saying, why on earth have we suddenly got all this dental disease, this dental decay? And he was seeing second generation, crowded mouths and so on. So he went looking, and he figured that anybody still on a traditional diet, not what became the typical Western diet, was still broad-arched, no decay, and very little disease. In fact, he thought the Māori the most magnificent of our species. And they have 11 things in common. Only 11. And that is low carbohydrate, low grain. Any grains are soaked or fermented, like your sourdough. High fat, so in the Mediterranean, for instance, a Mediterranean diet might be from 40 to 80% of their calories through fat. I mean, that sounds horrifying, but You know, you go around the Mediterranean, or, you know, at least as was, and there'll be plenty of 90-year-olds pruning their olive orchard. They are still fit, healthy, well, and not ravaged by all the chronic diseases that we see. So there is a difference between keto and low carbohydrate. And really it's just the difference between the carbohydrate count. So some of you will be aware of a ketogenic diet, and that's usually below 50 grams of carbohydrates in a whole day. That's about half a slice of Vogel's bread. And that's no potatoes, kumara, sweet corn, sugary fruit. That's none of that. If we just quantify it in bread form, that's all it is. And then a low carbohydrate can be low carbohydrate or moderate carbohydrate, and there's various cut-offs, like over 100, over 150, etc. And Richard Feynman wrote a wonderful paper, and I think it was so spunky of him to say, look, there's so much evidence in favour of low carb, high good fat, that it's actually up to the high carb camp to justify themselves, because you know what, they can't. So keto is very useful. I generally put people on a low carbohydrate rather than keto because I struggle with the lack of vegetables. So actually I learned a new wonderful term from Glenn today, ketovore. So it's basically being low carbohydrate, but you're eating lots of above ground vegetables. And it depends on what you're trying to achieve and who you're working with. I mean, if you've got cancer, you'll want to go hard out keto. But as for the rest, it depends on your activity level, your gender, etc., your age. But, you know, I really do believe that vegetables are a saving grace. I mean, we've all heard of wonderful stories of somebody having an absolutely shocking typical Western diet full of processed food, and then they become a vegan and they become so healthy until about 2 years down the track when they've run out of a lot of, you know, vitamins and minerals. They can't maintain the high carbohydrate, low protein input, and the wheels fall off. And it's the same with, you know, keto or other strict diets. It's got to be maintainable. It's got to be livable. It's got to be enjoyable. And it's got to be palatable. So I had a lady who had maculopathy. She was on keto, but she was eating a lot of animal products and dairy, and for a lot of people dairy is very inflammatory. So I asked her to increase her above ground vegetables, and the maculopathy just disappeared. So she escaped from having laser treatment, so she was pretty happy about that. And we decreased her protein intake because excess protein, as Glenn and I were talking about again today, will go into sugar. So you can't store protein other than in your muscles, and if you're not pushing weights, you're not going to increase your protein store. So it converts to sugar, which, you know, we know is a problem. So that's a little bit of a guesstimate of what 20 grams of carbohydrates look like. You've got half a bun or a whole plate of yummy vegetables. And I would move that with the shift in microbiome and all of the phytonutrients that are available to you in those vegetables, that would be by far your best bet. And I would always say, Popeye loves olive oil for a reason. He's the spinach man and she's the oil. And that's because a lot of the phytonutrients that you're eating in your vegetables are fat soluble. So unless you have fat in the same meal, which, you know, vegans do struggle with as far as enough fat, they're often in calorie protein malnutrition actually, you need that fat to help you absorb all the goodies. So that knob of butter on your carrots is really important, or on your peas. Animal products, you know, go wild. Just make sure they are clean, that they haven't been drenched, sprayed, GMO'd or whatever. You know, we've been living off this stuff for 750 million years. since we became, we came down from being chimps, depending on your viewpoint. But anyway, a long time, at least 35,000 years, as far as modern mans are concerned. And we've been eating this, killing it and eating it, for a very, very long time. So, free range, wild caught, as far as animal produce is concerned, and get some sun. Be sun safe, don't get burned, but brown yourself off slowly and gets that vitamin D inside you, because it's going to be an antioxidant and anti-inflammatory for your beautiful brain. I've helped somebody get over crippling social anxiety and depression just by giving them a high dose of vitamin D. It's more than just a vitamin. In fact, it's regarded as a hormone. Yes.
What levels are you currently recommending? Because I've heard people taking as much as 10,000 IU a day.
Yeah, absolutely. Yes, I know quite a few people. So those tend to be your autoimmunes, or sometimes cancer patients will choose to go that high. I like to be guided by levels, and some people need to intake a lot to get a movement in their level. So a level of 50 is regarded as being acceptable, which I think is grossly unacceptable, especially if you are a cancer patient, because vitamin D is known to feed your innate immune system, which is what you're relying on for cancer surveillance. So you need more vitamin D than that. So in this country at least, your level is regarded as being okay if you're 50 to 150. No, 200 I think? 200?
50 to
150, yeah, okay. And I like to get people well into that 1 to 150. And if they're a cancer patient, most definitely 150. Because it's just so very, very important for that cancer surveillance, and so many other functions. Healthy plant oils. So your olive oil is best taken at a very, very low temperature cook, or even better, just a cold drizzle over cooked vegetables or your salad. It is resistant to oxidation, but it's got one single double bond, and that, when it reaches a certain temperature, will become very energized and will react and grab onto the nearest oxygen. So it can be oxidized, which is why it's best for cold temperature cooking, cooler, like a saute. If it's virgin, as Madonna is pointing out the virtues of, then it is going to have all of its chlorophyll, carotenoids, aromatics, polyphenols, antioxidants, which are known to have therapeutic value. So there was a study done in Glasgow, and they treated people with markers for heart disease and stroke just with 3 tablespoons of olive oil a day. And all of their markers went down. So in itself, it is an antioxidant, anti-inflammatory medicine, as well as calories, and because it's all got these phytonutrients in. Coconut is another one of my favourite, because the S word, saturated fat. But if you think back to your chemistry, that means it's stable. It cannot be oxidized. All of its bonds are occupied. It cannot go anywhere. It is good to go, and it's going to stay good. And that is important when it gets carried around your blood in those cholesterol particles, because if it's an oxidized fat, it's going to be causing inflammation, and it's going to be causing furring up of arteries, poor blood supply, and aging, because that oxygen runs amok in the rest of your system. So it's pro-inflammatory. So coconut oil or other saturated fats, if they are drench-free, spray-free, absolutely virgin, thanks Madonna, then they are going to be heat stable and healthy. Not least because they carry all those goodies from the vegetables. They are able to solubilize your vitamin D, your vitamin A, your vitamin E, and your vitamin K, your fat-soluble vitamins. Without fat, you are not going to absorb any of them, no matter what's in your food. So coconut oil has also been found to raise your so-called good cholesterol, and it aids, it's a direct food for your gut lining, it's direct food for your liver. So we're kind of liking that. So beverages that I would suggest, oh yes, hello.
Have you, can you talk about good oil that's cold pressed and that they're selling nowadays?
Yeah, absolutely. You got it in one, cold pressed, because they're not going to ruin any of the other chemicals in there and they're not going to cause oxidation. You can almost do what you like with coconut because, as I say, it's saturated. You can't damage it. It smokes and then it burns, and you know it catches fire and it goes up the extractor fan. But your olive oil you can damage, and oh my goodness, don't even get me started on polyunsaturated fats. Many unsaturated bonds. Lots of opportunity for oxidation and therefore damage. And you know, in other talks I talk about the meteoric rise of age-related macular degeneration and lots of chronic diseases. The inflection point is when we started eating polyunsaturated fats and lots of carbs. That's when it started going wrong.
What I'm talking about is a product that's sold that's called good oil. I
Oh,
think it's rapeseed and there's another one they do. It's a cold pressed one, and if you read the back it says it's high in saturated fats. Do you know anything about that?
I don't know. I don't. I prefer pure oils, so I know what I'm doing with each. Because they all have, so I say to people, you know, try your olive oil for your cold drizzle and your saute low temperature sweating of your vegetables. And if you're frying something at low heat, then you could go for butter. If you're frying something at high heat, then go for coconut, because you just can't oxidize it, you can't damage it. Anybody put butter in the pan and forgotten about it and come back and it's brown? You've burnt it, bad, throw it out. Coconut, you can go and go. It's like a chip fryer, you know, just keep on going.
Isn't the rapeseed like the canola oil comes from the same thing?
Yes, I don't know as much about that as I should like to, but my inkling with what I do know, absolutely. You know what canola oil used to be?
I know.
Engine oil. And full of ricin. No, we don't like that either. That's really very, very toxic. So because of its history and I have to say, you know, Mother Nature knows best, and so does ancient man. So yeah, perhaps I'm using some cultural bias or emotional bias there, but you know, what I do know about canola is I don't suggest it. You know, the same with rice bran oil and all of these new oils. Just stick to your basics. Olive oil that, you know, a man pressed out of an olive, coconut oil that a man chopped out of a coconut, and butter that somebody squeezed out of a cow. You're probably going to be all right, because we've been on that diet for tens of thousands of years. You know, come back to me in 10,000 years when everybody's eating rice bran oil, I'll give you an answer. I hope that's satisfactory. Okay, so the other thing with diabetes is that inflammatory load. So there are beverages that you can utilize to reduce that. And something that is really, really commonly used and given to diabetics is green tea. That is anti-inflammatory, antioxidant, and it protects the photoreceptors, the actual cells that capture the light and transduce it into electricity to talk to the brain through all those lovely nerves that are running along through the retina. And they also protect your nerves and your blood vessels. It's just a wonderful antioxidant. So you can either drink 3 cups of green tea a day, or you can take the capsules, where you're probably going to get a higher dose of the acid that is actually known to be the active ingredient. But you know, I'm also a fan of whole herb medicine. So you know, instead of drinking the green tea, I'd say just grind it in your coffee grinder, put it on a spoon of yogurt and eat it. because then you're getting all of the water solubles and the fat solubles. So this is a really important thing when you're discussing herbal medicine. It's often how we deliver it that determines what's in it. And what we're after depends on what's wrong with you. But generally I'd say just eat the lot. And if you look at some of the healthiest, most beautiful people in the world, in my opinion, the Indians, I mean, I went to India, 20 years ago or whatever. Oh no, more than that. Okay, 30. And they were all gorgeous, with beautiful skin, beautiful teeth. The women had the most outrageously beautiful hair. Hardly any of them were fat, because they absolutely feed out on tons and tons and tons and tons of herbs and spices. And if you look at the list of anti-cancer herbs, the list of anti-this herb, list of anti-that herbs and spice, the Indians chuck it in their food like there's no tomorrow. Absolutely fantastic. Eat a curry at least once a week. Other herbs that are of significance, specific to diabetes, is rosemary. It's an antioxidant. It's neuroprotective. It's also, so it protects nerve cells, which is what you're talking about, your peripheral neuropathy, as well as the nerve cells in your retina. And it's an antioxidant, anti-inflammatory, but it also protects your cell membranes. So this is something that has been used in studies regarding radiation damage. So it helps protect your cell membranes against radiation. So if you're EMF sensitive, or if you are going in to have some radiotherapy, maybe loading up with rosemary a couple of weeks beforehand or 2 weeks afterwards, when it's done its thing, would be a good idea. And the thing that really excites me about rosemary is it increases blood flow to the brain, and therefore the eye, because embryologically that's where the eye comes from. It's a little outpouching from the brain, from the forebrain. So if you are able to increase the blood flow in the blood vessels that you have, then that's going to help protect your blood vessels as well as the tissue that they serve. Turmeric is one of those supreme antioxidants, and it's particularly interesting because as a fat soluble, it protects you from the oxidation of your fats, which is a big part of aging. It's a big part of the damage that happens with diabetes. And we also understand that that's a major culprit in cardiovascular disease, including heart attack and stroke. So bit of a magic super herb. It's protective against proliferative retinopathy, diabetic retinopathy, and proliferative vitreoretinopathy, and that's all been referenced. And by extension, because it's an anti-inflammatory, it will help you reduce your chances of getting an epiretinal membrane. I'm very much more, I'm certainly aware of the whole supplements industry and service, and you are the executor. You are the one that gets to make the decision and do your own research and figure out what it is that you feel as though you need, but do take advice, because you can overdo it, underdo it, spend a lot of money, double up, overdose, underdose. So supplements are more required if you have a poor diet. They do have a proven worth in diabetes, but it's easier to change your diet and probably cheaper. So what I say to patients is, you got to eat, right? So eat right, right? The other thing about supplements is, what else is in them? Is it bioavailable? Is it going to pass straight through you? Are you eating it with the right thing to absorb it anyway? Has anybody told you about these things? And, isolated things in too big a doses can be harmful. Sometimes they're oxidized, like fish oils. Oh my goodness. There has been so much written about the quality of fish oils. Before they even leave the factory, they're oxidized. So they have to be handled and processed very carefully. And you as a consumer, as a patient, need to be aware and choose carefully. And that's why taking advice from a naturopath or an integrative doctor who's got access and understanding, that would be useful, because otherwise it's tremendously expensive. So yeah, bottle or plate, you choose. Now for me, that looks a lot more yummy than a handful of pills. But there are caveats to that where you're going to have to, like people ask me about probiotics in yogurt. If you want to eat 3 litres a day, you be my guest. It's just not that strongly probiotic. So that's one of the situations where I'd suggest that other fermented foods that have been fermented traditionally, rather than our new paradigm of dairy where it's pasteurised and then inoculated and maybe even thickened or sweetened, it's become not what was originally intended. So kyolic ginger, kefir coconut, kyolic garlic, not ginger, kimchi, sauerkraut. So your fermented foods, really, really important for your microbiome, which is also damaged in diabetes. So this really is a global, body global problem. And if you go at it from as many directions as you can, then you're much more likely to succeed. On balance, however, there are a few things that diabetics are really, really in need of. And if you are able to isolate those things and eat accordingly, that's great. Magnesium. Magnesium is deficient in a lot of diabetics. So all you need to do is increase your leafy greens intake because they are high in magnesium. Vitamin D, you can either take it in a pill or be sun smart and get it from the sun. And you also, when you're out in the sun, you are outdoors, you are relaxing, your eyes are taking in Mother Nature and therefore relaxing your brain. They call it forest bathing in Japan. So a number of papers about forest bathing or green bathing, just the healing properties for your whole system of being outdoors. The photons that you absorb and pass through you and go into you are what navigates the dance between your electrons and your protons. We need photons. Go out and photon bathe, even if it's not sunbathing or vitamin D searching or tan pursuing, go and get your photons. Fish oils, good quality fish oil I think would serve most diabetics well. Green tea, as we talked about before. Turmeric, the king of anti-inflammatory antioxidants, and it's also an inhibitor of VEGF. So you remember that hormone that's driving all of this all around your body? This guy inhibits VEGF, and there are probably about 15, 20 herbs that do the same. So that's why they have a lot of crossover between diabetes and cancer, because a cancer can't grow without a blood supply. Multi-minerals, or you could eat lots of nuts and seeds, soak them beforehand to release the minerals, because otherwise they're bound up in phytic acid and you won't get them. So it's an evolutionary trick to not bud burst and go from the seed too quickly. The seed needs to soak in water, going, it's been around for 24 hours now, I think it's wet enough, I can sprout. Because if it kicks off too early, anybody been in the greenhouse and forgotten to water their seeds? You'll never get them back, because once that point's been interrupted, it won't happen. So it's one of those nature's tricks. So soaking in nuts and seeds is a really good idea. B12, if you're vegan, then nori seaweed. I also think it's in nutritional yeast to moderately low levels, but otherwise present in meat. And taurine is the other thing that I would suggest if you're vegan to definitely think about supplementing, particularly if you're diabetic, because you're going to need a lot of taurine. And even though we produce a little bit of it in our bodies, we don't produce a lot. So the rest of it we get from animal products like dairy and meat. Bilberry, my goodness, this is an absolute masterstroke, master herb for anything frankly, cataract, glaucoma, diabetes, but it's also the king of vascular herbs because it really helps support those basement membranes and tiny, beautiful cells that actually hold your blood vessels together and stop them being leaky, that lining. Ginkgo biloba, that's another one that helps the lining blood vessels. Those are the first ones to get distressed. And resveratrol is the other one, another wonderful antioxidant, anti-inflammatory.
So the dry herbs that you buy at the supermarket, are they still containing antioxidants and things? Or do you get your herbs somewhere else?
Nice question, really great question. The reason, I'll talk you through it. So has anybody ever grown basil and then thought, oh, I've got a bit too much, I'll dry it? And then you forget about it, and instead of green and dry and crispy, it's brown and dry and crispy. Okay, so now go to the supermarket and look at those bottles, which are absolutely tiny. I mean, that's half a meal. What am I going to do with that? Cook like a king. And that's why growing your own herbs, I think, is your best, even culinary herbs, not medicinal herbs, will be your best insurance policy against so many illnesses. And if you look at the Mediterraneans, I talked about the Indians previously, and the Asian traditions, goodness me, it's thrown in by the handful. It's another vegetable. And it's not brown. It's not oxidized. There's that word again. If you're a diabetic that's not on the right track, you're an oxidized, glycosylated mess. If I bit into you, you'd probably be sweet. So if you can mitigate those things as much as possible, you're doing yourself a really big favour.
Rosemary is a herb I find difficult to consume much of. What do you just grind it to a powder?
Absolutely. So any of these herbs that you're trying to grow yourself or take from, base ingredient, rather than the capsule, which is perfectly valid, then yes, grinding it up, drying it thoroughly, and then it'll keep, in a airtight, in the pantry, not on the sunny shelf, and then grind it to eat it. If you are going to take it like that, I would definitely take advice from a herbalist, because you're going to want to get the doses right, because some of these things can run through you pretty quickly otherwise, or have other side effects. So for instance, I had a tickly throat and starting with a bit of a snooty, snuffly, and I just couldn't, I don't have time for this. I'm going to load myself up with thyme. I didn't have any in the garden because my thyme bush had died and my little baby hadn't grown enough for me to start harvesting. So I used essential oil of thyme. And I knew that I couldn't apply it to my skin directly. It's one of the few that really burn, so you have to put it in a carrier oil. And I really just didn't want to have a cold, so I completely overdosed and gave myself a massive headache. It was worth it because, I didn't get a cold, but, you just got to know that they are medicines and you've got to treat them with, a certain amount of knowledge and respect, because you can do yourself harm. So, but there are health shops everywhere, there are herbalists everywhere. And, read, go look, buy a book, go to the library.
That was soaking with nuts. Even a thing like a walnut should soak that in water first.
Everything. Because they've all got phytic acid in them.
So how long is it soaked for?
Oh, just overnight.
Just a...
Mm-hmm. Well, I mean, even if you wanted to do it for a few hours, that would start the process of disintegrating that phytic acid, which is binding all of those minerals, which the enzyme systems in the seed need to start the sprout process.
So if you just eat them dry, you'll be wasting half.
Oh, you've still got the oils and the proteins and the fibre, but you're not getting the minerals. So, when you say, oh, well, I'm eating Brazil nuts for selenium, maybe not, yeah. Back to what the lovely lady in the flowery shirt said about, doses and so on. As a rule of thumb, your leafy herbs are about 5 grams 3 times a day. You can get those little wee scales that are very tiny amounts and tenths of a gram, etc. Or you can just say, well, it's about a teaspoon, that might be 5 grams. For your root or hard or woody or seed-based herbs, medicinal herbs, your dose is more generally, as a rule of thumb, 1 to 2 grams 3 times a day. Okay. Oh yes, so here we go. I've introduced you to some of these anti-angiogenic herbs, which if you had diabetic retinopathy, you might consider consuming. We've met green tea and ginkgo biloba already. Curcuma longa, that's the turmeric. Bakel skullcap, that's one of my favourites. I use that for my glaucoma patients. Yeah, so you can have a think about that, but you'd probably want direction from a herbalist at that point.
How do you feel about making a smoothie up with spinach and or put all those like your rosemary, your green tea, everything in it, and some yogurt, and have that in the fridge to
Sup throughout the day?
Yeah.
Yep, absolutely, absolutely. I wouldn't put spinach in it every day because it's quite high in potassium. So I'd counselled one of my age-related macular degeneration patients about spinach, but lots of variety of vegetables, above ground vegetables. And I said, now don't overdo the spinach because it's high in potassium. It will give you an arrhythmia. And he came back the next time and he was a bit sort of sheepish. Oh, how have you been? And oh, wow, I ended up at my doctor's and I was having heart palpitations, and he checked my potassium, and then he rang me in a great panic saying, your potassium's really, really high, get to hospital. He's like, yeah, I know what I've been doing. Okay, I'll stop. So, you know, variety and seasonal, you know, we say these things for a reason. You can go hard out and you know, run into some unexpected consequences. So that variety and seasonal is important. And that's, again, you know, classically and anciently how we've been eating and living. And also you'll meet fresh stuff that hasn't been stored. I mean, you know, apples get stored for months and months. That's just one. So yeah, just going on through the cautions, but yes, great idea. Cautions and contraindications. Vitamin D, you can overdo it. You can end up with calcium because it's involved with calcium metabolism, getting calcium left around where it's not really wanted. Your fish oils at a dose of about 4,000 milligrams daily will be anticoagulant. Something of interest for people who actually want to use it for that purpose. Green tea, you've got to be careful if you're on warfarin or a certain type of antidepressant, monoamine oxidase inhibitors. And it reduces the anti-cancer effect of some of the chemos. So if you are taking herbs through, in addition to conventional treatments for cancer, then I would absolutely say, for goodness sake, please work with a naturopath or herbalist. Because by moderating and modulating when and what and how much, your side effects can be reduced, your dose could be reduced, the duration of your treatment could be reduced. And it's a clever dance, which, you know, full disclosure needs to be operating.
I was just going to congratulate you on referencing Mills and Boon.
Mills and Bone, yeah, absolutely. But love is very important. That's also a good medicine too. Good point. Turmeric. You've just got to be careful with people who have got gallstones, because it increases the flow of bile and the production of bile, and it makes the gallbladder squeeze, which is great when you've got a high fatty meal coming on board. You need lots of bile to make those into little micelles and help you break up the fat. It's not that it's contraindicated in gallstones, just be careful, because an overdose could see you with, you know, quite a nasty attack. Your gallbladder is really, really important. If you have got gallstones, go and see a naturopath and get them sorted, because once you've lost that gallbladder, you're going to be in a lot of difficulty dissolving all of that beautiful fat that we're encouraging that you eat. And a high dose, once again, is thought to have an effect on anticoagulants. So this has been a lot for you to swallow, but when people look at me and say, well, how am I going to do all that? You go, well, one step at a time. And that's a famous Taoist saying. And you can eat your way out of trouble one bite at a time.
I've got a microphone here. If anyone would like to ask a question. If you would like to ask a question, just introduce yourself and ask away. We've got 10 minutes or so. Don't forget to introduce yourself.
Jackie, what's your thoughts on floaters in the eye?
Okay, so floaters most commonly is representing a chronic degenerative change in the protein fibres that make up the gel. So ever bought a fresh egg or had it laid that morning, you crack it and it's like a pert little gorgeous thing with the white standing up and the egg yolk standing on top of that. All the proteins are fully able, they're healthy, they're able to hold on to the water. When you crack an old egg, because the proteins are just not holding on to that water. And that's what's happening in the jelly part of the eye. And those abnormal proteins that have been oxidized and glycated and all the usual stuff start to clump. And they clump so much, instead of being spread out with all that lovely water in between, it clumps, and it's so clumpy that it's actually dense enough to cast a shadow on the back of your eye, which is why you can chase the little critters across a white wall and they'll chase you back again.
How do you minimise them?
Minimise them by exactly what we were talking about, is a low carb and high good fat, high nutrient density, antioxidant, anti-inflammatory, traditional diet. That's where you avoid them. Getting rid of them once they're formed is a little more tricky, but all proteins turn over in life. The eye is not so active, particularly the lens. That's really very, very difficult to access. There are other means if they're right near the front of your eye, which you're less likely to be bothered by actually, because if you think about the shadow being very, very diffuse by the time it gets back to the retina, they are accessible by laser. So some of them are accessible.
Are there any more questions?
I like having infrared saunas. I invariably get out and get told that my eyes are bloodshot. Is that good or bad?
There are a couple of things that are probably happening. A sauna, the air is very dry, and your conjunctiva, the part that's going bloodshot, the part that's sitting over the top of the white of your eye, is there for lubrication, to produce a little bit of mucus, you know, like the slip on the inside of your mouth. It's to produce a little bit of that so your eyelids can glide nicely while they're distributing the tear film over the front of the eye, over the cornea, to keep that really nice and clear. And when you're in a dry environment, it's all having to work a lot harder. So you're getting extra blood flow to do what it does, and it gets dried out and it gets distressed. So not such a good idea. Everything dilates a little bit when you're warm, but it certainly shouldn't be to the point where you've got bloodshot eyes. So I would suggest it's the former. So perhaps relax in there with your eyes closed.
Hi, my name's Annie, and I'm just wanting to know, it happens with my husband, and I've seen it in people at work, bloodshot eyes, and suddenly they get up, like one lady came to work today and she had bloodshot eye, really bad. I said, what have you done? And what's causing that, and what can you do to stop it from happening?
Okay, that can be perfectly benign in that, you know, they are fragile blood vessels, and as you get older, it tends to happen in older people. The support tissue around those blood vessels that, let's face it, are right on the surface of your eye, they can be seen. It's like an internal vasculature that's on the, you know, in touch with the world. So they are very delicate, and if that connective tissue is withering, like our connective tissue tends to as we get older, and that's why everything heads south and wrinkles, etc. It's kind of like the same thing in the conjunctiva. However, it is also relatively more frequent in people with uncontrolled blood pressure. So I think anybody who has one, I would always say, well, what's your blood pressure? Is that okay? Should we check it? And if not, let's do something about it.
I'll go next. Hello, my name's Margaret. I was wondering about cataracts and using oil, castor oil.
I have a number of papers published on the use of castor oil for dry eye and meibomian gland dysfunction and blepharitis. So we did that at the National Eye Centre at Auckland University. Tremendously fantastic oil with amazing properties. But the cornea is a real tricky dicky in that they will only let certain things across. So it's part of the executive function of what goes into the eye and what doesn't. So when we formulate eye drops, we've got to be very particular about, right, what's going to bind onto, how's it going to get through that first layer, how's it going to get through the body of the cornea, and then how's it going to get into the water of the eye, and then where's it going to go and where's it going to bind to. And castor oil is not one of those things. So the other thing about the lens is it's a very tight ship. It doesn't really like letting a great deal in and out. That membrane is also very much controlling what's going on. And okay, so when you go swimming and you've been in a long time, your fingers go wrinkly. That's because the proteins in the keratin in your skin has absorbed water, just like the protein in the jelly of the eye. So it swells. So your finger is bony on one side, so it's got a limited circumference. And now you've got a bigger surface area, so it becomes wobbly to take up that extra volume, take up the extra surface area. If you didn't have a lens capsule, to keep out the water and anything in it, almost, you know, assiduously, with a little bit dripping in to give some goodies, then your lens would become very swollen and opaque. So when we get eye injuries, perforating eye injuries, even the smallest, tiniest nick in that capsule, you can bet the next day at least they'll have a cataract. So getting anything into the lens is a real mission. So N-acetylcysteine was looked at some years ago, and somebody brought out a commercially available eye drop, very expensive, on the basis that it's an antioxidant and will pass into the lens. I've only trialled it a couple of times and I've been a bit disappointed. So the hunt is still on for something that will be antioxidant and that can pass the fortress of the lens capsule. So I'm afraid the answer is probably no.
I'm Karen. I have a lot of trouble with night driving. I do wear contact lenses, and I always think that it's the car lights reflecting off my contacts. Is that right? And how can I help night driving?
Okay, when you say reflecting, can I introduce a word as an idea or as a description? Is it something that you would describe as glare? You lose your contrast sensitivity, it kind of, the light seems to bounce all over the place. Okay. Is this only occurring when you've got your contact lenses, not your glasses?
I don't have glasses, so I wouldn't know.
Okay.
I only have contacts.
Okay. So I would suggest that this is not the contact lenses, that it is possibly your lens that is starting to become a little bit cloudy, and those proteins that are starting to misfold and clump are creating a scatter, which is what you're experiencing as glare. It's just early changes and, very early changes, and they may go nowhere. But the contact lens is almost a perfect optical addendum to the front of your eye. So it's literally another cornea that somebody slapped on. Optically, they are really almost impeccable, especially the soft gel or, whatever they're made of, even the hard ones. So I would move that that's possibly what's going on. So you might want to visit your optometrist and get them to have a look. And then consider your vegetables and your bilberry intake.
How do you take, bilberry is a berry, isn't it? Yeah, so can you buy bilberries?
So bilberry is in quite a few formulas, and you can buy things with 1 ingredient, 4 ingredients, 15 ingredients. And when you're looking for something of therapeutic level, of absolute requirement for your particular problem, I would suggest you want to have maximum dose. So that's when I would go for a single herb or single nutrient solution. And as a practitioner, there are practitioner-only herbals available, but you can also buy them online. They're ubiquitously available from all sorts of outlets online. And you can go and buy yourself a pure bilberry.
Do you practice in the eye clinic here in Taupo?
No, I have my own clinic in Kati Kati.
Oh, okay.
Yeah.
But Emma is also going to be down here once a month, so she is available for consultations about any area of her expertise, so not just about eyes, but as an integrative medicine doctor, as a herbalist, as a naturopath, as a very good listener. So she is available for consultations once a month.
Reversal clinic?
A reversal clinic.
Hi, I'm Juliet. I have a friend, and this may not be the right time to talk about it, but she's a type 1 diabetic, and she suffered a stroke and has visual field loss, field vision loss. Mm-hmm. Is there anything that can be done that you know of?
Do you happen to know if this visual field loss is subsequent to the stroke?
Yes.
How long ago was the stroke?
Almost a year ago. She's trying to find someone to help her. No one seems to know much about it.
Yes, the brain's a bit of a fickle puss. Once you cut off its blood supply, it's not very happy. It does. We understand far more about the brain and brain injury now. So we used to say to stroke patients, "Oh well, that's it." But people who eat right, do right, and work at it have achieved enormous gains in their function. I have not heard of anybody who has been able to recover their visual field loss from a stroke. Perhaps it's not well reported, perhaps it happens, perhaps it's a particularly sensitive part of the brain that just won't. It is a very specialised part of the brain, and when we talk about neuroplasticity as far as getting around any injury, it's about workarounds and reconnections. But considering how well organised the visual cortex is, if you think that for us as primates with colour vision, we have great reliance on our visual system. Your visual processing actually starts in your retina. It's already happening. Contrast sensitivity, black, white, where are the boundaries, where are the edges, who's moving, who isn't, in relation to what. And then all of the processing that goes on in your visual cortex, which is right at the back. Then there's distance, depth perception, speed of movement. It's just mind-boggling. So that may be part of it, but as I say, just because I haven't read it doesn't mean it's not out there. So tell her to maintain suitable optimism.
So you haven't had any cases yourself? Get onto the rosemary.
Yes, and prevent any further insult to her brain.
Thank you.
My name's Lynn. 2 years ago, I was put with the public health, but then put into the eye clinic in Rotorua. It started off with my eye just leaking all the time. And I used to go over there and have every 8 weeks and have an injection into the eye because I had a build-up of fluid in behind the eye. And when they scanned it, it would go there and then like that. Probably about 6 months after being there, they did a cataract operation. And then, cataract operation, then they carried on with the injection. And in November last year, I had the Cowboys taped to me with the laser treatment. So I got works there. I've been back 2 weeks ago, and he doesn't want to see me for 3 months. Everything is improving, and I'm not getting the leaking so much. And it's just a matter of, since November, my eyesight and that eye has been improving. So it's just a matter of patience, isn't it?
Magnificent job, yeah.
And if you've got to have injections in your eyes, it does not hurt.
No, I mean, I've done thousands, and, mostly... No, not a bit.
They give you eye drops, and I used to have little wee black things going across, which would be the blood vessels, wouldn't it, after they put the injection in. Yeah.
It just could be the density change. You know, when you're walking across a bridge or you peer into a stream with a hot spring going into it, you'll see the density change because of the refraction and diffraction is different in a hotter fluid than a cooler fluid. So when you've got a dense fluid being injected into the eye, you'll often see the diffraction pattern that creates before it mixes. Yeah. So that's possibly what you were saying.
Yeah.
This will be the very last one.
Hi, my name is Valerie. So lots of people said to me in my 40s, when you get to your late 40s, your glasses, your eyes are over the back, yada. And now that I'm 40-11, I've definitely noticed it in the boot body, and I feel like it's come on very quickly, and my eyesight's getting worse and worse. Is there herbs, things I can take that are going to help perhaps stop it from getting worse?
What sort of difficulties are you having?
Reading.
Yeah, absolutely. That's called presbyopia, and that's because the lens of the eye gets stiffer and stiffer with these, consequential protein changes. It's kind of the opposite to wrinkles and sagging everything. The elastin's going there, but in the cataract, in the lens, it's becoming stiffer and stiffer. And your poor muscles that are, they're just getting a little bit unable to wield such a stiff little brute. So it's becoming harder and harder to, your arms aren't long enough anymore. Now you're really lucky that, you're 11 to 40, and you know, you missed out on 11 years of that presbyopia. It's possible that that's because you're short-sighted for long distance, no?
I'm fine driving,
Mm.
no problem.
Okay.
Although I've had moments of driving at night for a job where I get quite fuzzy, but that hasn't happened for years. But yes, no breathing.
Yeah.
My arm's not long enough. I'm wearing some basic glasses. But had my eyes checked, they said there's some aging spots and things. But yeah, I just sort of wondered, is there something that can slow?
Yes, absolutely. And guess what the answer is? Herbs and a great diet, just as we've been talking, because that is an aging process. So this is something that continues to amuse me when we talk about age-related anything. You know, before, okay, so the ophthalmoscope was invented in around 1927, I think, and you know, the reported cases of age-related macular degeneration were really, really rare. Okay, you can say, well, it's an expensive piece of kit, maybe not very many people had it. But then as the diets started to change much more precipitously, it just took off. There was an inflection point. And so this is age-related, right? Okay, so we go to our Greek olive pruner. Has he got it? He's 90. It's a diet and lifestyle disease. Cataract, okay, yep, sunshine, UV, poor diet, but it's a lifestyle disease. It's more common when you're old because you've been on said diet and, you know, it gets a little bit more creepy and creeping, but you can grow old successfully and youthfully, you know, with the right input, the right attitudes, you know, your emotional, spiritual cleanliness, detoxing your environment. It all has a massive impact. Massive impact. And when you see people who are on bad diets and who have inflammation on board because of said poor diet or poor emotional well-being or poor environment, they're inflamed and they get all of these age-related problems at 30. What the what? So yes, there is.
All right, so it just leaves me to say a huge, huge thank you to you. Huge acknowledgement of your comprehensive knowledge, and you're just realising what you know about eyes to that degree of detail is, I don't know, I kind of go and just, wow. And then to hear the herbal and the naturopathic part on top of that. So we're very, very privileged that you have come all the way down here to talk to us. Thank you also very much to Warwick, who will turn the talk into a high quality video, which we'll put up on the Facebook page and in other places. So these meetings will be on the second Wednesday of the month, once a month from now on, and hopefully we'll be able to find other speakers of the same quality that we've had tonight. So thank you very, very much.